Hello and welcome back to the YouTube channel. Today we're going to be looking at thyroid function tests and more importantly, how to interpret them in clinical practice. My name is Camille, a clinical education company that delivers CPD accredited education across the UK for various healthcare practitioners. Be sure to visit our website for more enriching content. So, thyroid disorders. These are more common than many people realize. In the United Kingdom, about 2 in every 100 people are affected by hypothyroidism, and the condition is significantly more common in women than in men. The prevalence also increases as people get older. On the other side of the spectrum, hyperthyroidism affects about 1 in 100 people, with Graves' disease being the most common cause amongst younger adults. These are not rare conditions, and because the thyroid has such a widespread effect on the body, getting the interpretation of blood tests correct is an essential skill. And why does it matter? Well, symptoms of thyroid disorder can be very non-specific. Underlying thyroid pathology can present as fatigue, weight gain, weight loss, hair changes, bowel habit changes, palpitations, and even affect your mood. All of these things can be explained by other factors. However, without careful interpretation of the blood test, it's easy to miss a thyroid problem or even misdiagnose one. So today we'll cover the essential background, then move on to 2 cases to consolidate these key points. So starting with some basic anatomy and physiology, because everything in the thyroid interpretation comes back to this. The thyroid itself is a butterfly-shaped organ sitting in the lower part of the neck, just below the Adam's apple and wrapping around the trachea. Despite the small size, it does have an out of proportion influence on the body's metabolism. The thyroid produces 2 key hormones, thyroxine, also known as T4, and triiodothyronine, also called T3. T4 is produced in larger quantities, but T3 is biologically more active. Most T3 in the body actually comes from the conversion of T4 in the peripheral tissues. Now, the thyroid gland doesn't work alone. It's controlled by the hypothalamic pituitary thyroid axis. The hypothalamus in the brain produces TRH, then stimulates the pituitary gland to release thyroid stimulating hormone, or TSH. TSH is the main driver of thyroid activity. It influences the thyroid to produce and release T4 and T3. And here's the most important part. There is a negative feedback loop. If circulating levels of T3 and T4 rise too high, they signal back to the pituitary and the hypothalamus to reduce TSH production. Conversely, if thyroid levels fall, the pituitary ramps up to try and push the thyroid harder. And this is the foundation of interpreting thyroid function blood tests. A high TSH usually means the body is trying to compensate for low circulating thyroid hormone levels. On the other hand, a low TSH usually means thyroid hormone levels in the blood are too high. But as we'll see in these cases, there are nuances and exceptions, and that's why we need to interpret these numbers carefully. So here's case 1. We've got a 32-year-old lady who presents to her GP with several weeks of symptoms. She has been feeling increasingly anxious with a racing heartbeat, some difficulty sleeping, and various episodes of profuse sweating. She has lost weight despite feeling hungrier than usual, and she's noticed her hands sometimes shake. On examination, the doctor notices a fine tremor, arresting tachycardia, and a visible swelling in the neck, suggestive of a goiter. Her blood tests show the following results. Please pause the video and take your time looking at these and trying to think about how you would interpret. So, how would we interpret this? Her TSH is suppressed to almost 0. That's the pituitary gland telling us there is too much circulating thyroid hormone. And indeed, both free T4 and T3 are markedly elevated. This is the classic biochemical picture of thyrotoxicosis. And what is the underlying cause? In a young woman presenting with goiter, the most obvious unlikely diagnosis is Graves' disease. Graves' disease is an autoimmune condition where the body produces antibodies that mimic TSH and stimulate the thyroid continuously. These are called TSH receptor antibodies, or TARAB. So beyond just the thyroid function test, we would request antibody testing. A positive TRAB result suggests the diagnosis of Graves'. This is important because treatment decisions, whether anti-thyroid medication, radioactive iodine, or surgery, often hinge on confirming the underlying diagnosis. So this case illustrates not only the importance of interpretation, but also thinking about the next steps. Do they confirm or deny the diagnosis? and what further testing is needed. Here's case 2, which highlights a very different but equally important issue. In this case, we have a 58-year-old woman with a history of hypothyroidism. She has been on levothyroxine replacement therapy for several years. Recently, she reports increasing tiredness, dry skin, and constipation. You check her thyroid level and find her TSH is elevated, so you increase her levothyroxine dose. 6 weeks later, her blood tests look like this. Have a pause of the video to see what you think. So despite the dose increase, her TSH is still above the normal range and her free T4 is at the very bottom of the range. This suggests she remains in a hypothyroid state. In other words, her replacement therapy is still insufficient. At this point, it might be tempting to simply increase the dose again, but we need to consider why the therapy is not working. One key factor is absorption of levothyroxine. Levothyroxine must be taken on an empty stomach, ideally first thing in the morning, at least 30 minutes before eating. Food can interfere with absorption, so even more importantly, several medications can interact. Iron supplements commonly used for anemia can bind to levothyroxine and prevent it being absorbed. Calcium carbonate, often used for osteoporosis, has the same effect. Proton pump inhibitors such as omeprazole or lansoprazole also reduce the stomach's acidity, which can impair the absorption. So in this case, rather than increasing the dose again, it would be wise to check with the patient how she's taking the medication, whether she's spacing it properly from other drugs, and whether the absorption issues could be because of an underlying problem. This kind of clinical reasoning prevents unnecessary dose escalation and helps achieve stable thyroid function. So to wrap up, let's summarize what we learned. Interpreting thyroid pathology relies on understanding the TSH, T4, T3 relationship and the negative feedback loop. A high TSH usually means low thyroid hormone levels, and a suppressed TSH usually means high thyroid hormone levels. But always consider the bigger picture, including patient's symptoms, examination findings, and any medications they may be on. In our first case, we saw the classical biochemical signature of thyrotoxicosis with a suppressed TSH and elevated T3 and T4 pointing towards Graves' disease, which can be confirmed with an antibody test. In our second case, we saw persistent hypothyroidism despite treatment. The key learning point here was to think about absorption and drug interactions rather than simply increasing doses. Understanding these patterns and applying them thoughtfully in practice allows us to make more accurate diagnoses, avoid pitfalls, and ultimately deliver better patient care. So thank you for watching. If you found the video useful and helpful, please like the video, subscribe to the channel, and share it with your colleagues and classmates who may benefit. And as always, leave your questions or comments below, and we'll be happy to go through further detail in a later video. So thank you very much for listening, and we'll see you on the next video.